Thank you, everyone, for coming to the room this afternoon for the poster presentations. And welcome to this year's 2021 Matrix and GP Track Summit, featuring disruptive technologies and innovations. During this poster session, we'll have 3 posters presented outlining projects in telehealth that will give insight into the innovations and present new ideas to consider. Detailed data gathering and research into each of these areas is what makes understanding telehealth research beneficial to all of us. We're grateful for our presenters and willing to share their findings, and that you will come away with a better understanding of telehealth. Each presenter will be given up to 10 minutes to introduce themselves and explain their poster, with the remaining 4 minutes left for questions and comments. If you prefer, you may also use the chat feature on your screen to ask questions. We want to thank all our poster presenters and our audience for joining us today. Also, we encourage everyone to vote for the People's Choice poster presentation in the Summit app. And when you go to the main page, it'll be on the left-hand side. It'll just say, vote for People's Choice poster right underneath the title posters. So if you have any further questions or would like to continue any discussion with our presenters, feel free to connect with them at the summit. To do this, review the attendees and then message them to connect at networking tables in the exhibitor space or email them. So we will move right along. Our first presenter today is Erin Bronner, and she is going to speak about her poster, The Impact of Remote Patient Monitoring on Healthcare Utilization in Pediatric Pain and Palliative Care Patients. So Erin, I'll let you take it away.
Thank you so much, Tim. I really appreciate it. Again, hello, good afternoon, everyone. My name is Erin Bronner, and I am a doctoral nursing student from Old Dominion University in Norfolk, Virginia. My study is the impact of remote patient monitoring on healthcare utilization in pediatric pain and palliative care patients. My faculty advisor is Dr. Tina Gustin. Currently, healthcare is on the rise. The healthcare cost is on the rise. It's grown about 4.6% to $3.8 trillion in 2019. As a way to potentially mitigate the rise in healthcare costs, there has been some proposals of decreasing costs or decreasing funding to CHIP or Medicaid, which could negatively impact children. In 2018, actually, CHIP funding lapsed for 114 days, putting 9.6 children at risk. As a potential way to provide quality healthcare to children while mitigating the rise in healthcare costs, remote patient monitoring techniques and telehealth techniques could be utilized. Remote patient monitoring devices, such as the Resideo tablet, which was used in this study, collects healthcare data from patients' homes and transmits it securely to their providers. Potential aspects of care, such as like vital signs or messaging, they even used it for video assessments or treatment management, and touch points were also monitored through this remote patient monitoring device for these patients. It's currently unknown if remote patient monitoring devices have any impact on the healthcare utilization in the pediatric palliative care population. Specifically, can they be used for scheduled visits? Can they be used for monitoring touchpoint communications between patients and providers? It's unknown if it has any impact on the number of missing visits that patients would miss, or does it have any impact on how often patients go to the emergency room or how often they're hospitalized? And we aren't really sure how remote patient monitoring technology impacts provider workflow for these patient populations. Potential evidence could aid in remote patient monitoring reimbursement in the country, which might decrease healthcare resources and also improve provider workflow. In this study, my population was from a pain and palliative care clinic based out of Children's Hospital of the King's Daughters in Norfolk, Virginia. My sample was recruited from a 20-group patient, year-long remote patient study that was already going on. The age of these patients were 8 months to about 26 years old, and they were receiving care from this CHKD clinic. They were broken into 2 groups. The first group was using remote patient monitoring equipment, the Resideo tablet, in their homes, And the other group was using usual care. And that included home-based visits as well as in-person clinic visits and also telehealth Zoom visits. However, in the setting of COVID-19, that usual care did change. No one was using inpatient or in-clinic visits or home visits just because this is a vulnerable population and they wanted to decrease the spread of COVID-19. So those patients primarily used only Zoom visits, whereas the remote patient monitoring group only used the device itself for all of their visits and communication. This method was a retrospective two-group design. I was collecting data strictly from the electronic medical record. I was not having any interaction with these patient populations. The data was collected by a data governess over a period of 6 months, and only descriptive statistics were used for the study because my sample size was very small. My research question was, is there a difference between children receiving pain and palliative care services that are utilizing remote patient monitoring equipment and those that are not, related to specific visit types? And the results that I got, I thought were pretty interesting. Although my group was rather small, I had a total of 7 participants. There were 4 in the remote patient monitoring group and 3 in the non-remote patient monitoring group. The age of the remote patient monitoring group was a little bit younger at 5 years old, whereas the non-remote patient monitoring group was about 12 and a half. There were overall more males in my complete sample. In the remote patient monitoring group, they had more males than females, and they had more African-American participants than any other ethnicity. And they primarily were divided between Medicaid insurance and private insurance. The non-remote patient monitoring group, again, like I said, was older, had only males in it, was primarily white, and had only private insurance. And looking at our visits, overall, you can see there were a total of 108 total touch points, which made up for 94% of all the touch points in this study. So majority of all communication that was occurring happened with the remote patient monitoring group. The remote patient monitoring group also had more scheduled visits than the non-remote patient monitoring group. And they also had an additional 41 visits in addition to their scheduled visits, whereas the remote patient monitoring group didn't have any extra scheduled visits or any extra visits at all. So that automatically says to me that the remote patient monitoring group is having more communication with their provider compared to the usual care group. It's also interesting to note that the duration of remote patient monitoring visits was actually about the same as usual care visits, and it wasn't really shorter or longer at all. And although a small difference, there were fewer emergency room visits and hospitalizations in the remote patient monitoring group than in the non-remote patient monitoring group. And they also spent less time in the emergency department, or they had fewer or a shorter length of stay in the hospital, which is interesting. And there was only one missed visit. There was in the remote patient monitoring group, whereas the non-remote patient monitoring group did not have any missed visits. So what is all this saying? Well, I think one of the biggest take-home points is that the utilization of remote patient monitoring techniques can be used in this vulnerable population, which was not known before. And it also shows that they are actually using it really well. They're communicating with their providers pretty frequently. And this also is telling us that if you're considering utilizing remote patient monitoring equipment in your facility or clinic, that you need to make sure that you're staffed appropriately, because usual care visits could be one lower amount, but you're going to increase your volume substantially, and it could lead to provider burnout. So preparation seems pretty key when integrating this technology. Also, it's important to note that the remote patient monitoring group did have a missed appointment, which could be because scheduling appointments is very easy with this device, and they maybe didn't value scheduling as much, but it's kind of hard to say. And it's really unknown also if there was a decrease in emergency room visits and hospitalizations because there was increased communication with the remote patient monitoring device. Honestly, there's just not a significant difference, and we weren't able to run significant statistics to really prove any of those statements. And some limitations of the study, like I've kind of been saying, is that it was a small sample size, so we weren't really able to run anything more significant than descriptive statistics. And but there is plenty of room for where we could go with this study. I think it would be really impressive to repeat it with a larger sample size and see if we can run some more meaningful statistical analysis. I think also it would be really interesting to see if remote patient monitoring appointments or visits are different, have any differences between home visits or the in-person clinic visits like they were kind of prior to COVID-19. And that won't be really able to be possible until COVID-19 restrictions have been safely lifted. And lastly, I think the big piece would be to see if this study is replicated on a larger scale and you continue to see this trend of fewer emergency visits and fewer hospitalizations, what's the financial aspect of that? What is the cost analysis that's coming from that? And is it making an impact and decreasing the cost on our healthcare system, which are all, really important, I think, pieces that are kind of starting to be opened up with this investigation of this topic. But that's all I have for you all, and thank you for your attention. I'm happy to answer any questions that y'all have.
I didn't see that this was part of the study, but I wondered, did you have any indication of the satisfaction between the groups at all?
That's a really great point. I actually didn't look at the satisfaction, but actually in the next poster presentation, Lacey Bloy will be investigating that piece of satisfaction of caregivers in remote patient monitoring with similar groups. So that might be something to check out. She has some pretty interesting results, I think.
Thank you.
Yeah.
Any more questions? I don't see anything in chat, but we do have time. You can open up your microphone if you do. Sometimes that's quicker. Okay. Well, if not, well, thank you very much, Erin. Excellent work there. And then I hope you do get to go back and revisit that and get a larger patient panel too. That'd be fantastic. All right. Next we have Sharon Thompson, who's going to present her poster on patient experiences with ambulatory telehealth and neurology. So Sharon, if you want to go on and share your screen. Perfect. Thank you.
Are you able to see the full screen?
Yes, we are. Mm-hmm.
Okay. All right. So my name is Sharon Thompson. I am a fourth-year medical student at Wake Forest School of Medicine in Winston-Salem, North Carolina. And our neurology team studied qualitative patient experiences as we transitioned into ambulatory telehealth and neurology during this COVID-19 pandemic. So we all know that telemedicine has been around for a while, especially since the mid-2000s with the implementation of telestroke. The main benefit of it was expanding care to patients in rural areas where they lacked subspecialists, and also to patients with limited mobility or lack of transportation. But telemedicine really kind of kicked off during this pandemic as we were kind of forced into this paradigm shift in care delivery. And so, although previous studies have looked at clinical and financial benefits of telehealth, including the elimination of travel expenses and improved triage of patients needing tertiary care, no study had kind of comprehensively looked at the current and future role of telehealth in ambulatory neurology through qualitative patient experiences. So our study specifically tried to quantify and characterize the patient perspective during the implementation of telehealth in the COVID-19 pandemic. So we conducted a sequential mixed method study that first involved a quantitative survey, which included 3 multiple choice questions for patients undergoing these telehealth visits. This was then followed by a qualitative assessment of the patient experience, including benefits, challenges, and patient recommendations. So the quantitative multiple choice survey included 3 questions. So that question number 1 was, at your recent visit, what type of telehealth visit did you have? Was it video only, telephone, video that had to be switched to a telephone, or anything else? Question number 2 was, how well did the telehealth visit meet your neurology needs? Were all of your needs met, some of your needs met, a few, or none? And then the 3rd question was, would you want to have a telehealth visit in the future? Definitely would consider, might consider, only if it's required, or no. And then the last question sought general feedback from patients, including surprises, challenges, benefits from seeing the neurologist in a telehealth visit. So so a total of 2,280 patients completed a telehealth visit during this time. We were able to contact a total of 753 patients. And of those patients, only 551 provided qualitative feedback. 46% of the visits were by video, and 53% were by telephone. In terms of the quantitative study results, we see that 77% of patients who had a video visit said that all of their needs were met. Similarly, 76.6% of patients who had a telephone visit also said all of their needs were met. For their response to question number 3, for whether they would consider a telehealth visit in the future, nearly 57% of patients who had a video visit would say that they definitely would consider a visit, versus 45.9% who had a telephone visit said that they would definitely consider a telehealth visit in the future. When we assessed the qualitative responses from the 551 patients who assented to that part of the study, there were 6 major categories of thoughts that emerged. First was the attributes of a positive patient experience. Second was attributes of a negative patient experience. Third was any COVID-19 related specific experience. Fourth was technology satisfaction and limitations. Fifth was factors that patients thought were important for successful integration of telehealth in the future. And lastly, patient reported suggestions for optimal scenarios in which telehealth could be used. The positive patient experience, 32% of patients talked about this. And what those included were anything in terms of overall benefits, like reduced wait time, no transportation, no commute time, things like that. Having a positive interaction with the physician. That was another one that was very commonly reported. In terms of things needed for a good interaction, patients reported that they valued administrative help in setting up the visit. Now, when we look at attributes of a negative experience, 14% of patients talked about this. And the main thought that came out of that was a lack of a comprehensive neurological exam. One patient in particular said something along the lines of, I just don't think he can see me and the way I'm walking or my strength with the video visit. He can only hear what I can tell him. Other reasons for a negative patient experience include delayed administrative tasks between the physician and the laboratory office, or a negative physician interaction, or billing concerns, or miscommunication of any sort. When we talk about COVID-19 specific experiences that patients talked about, 20% of patients talked about this, and they talked about wanting an in-person experience, regardless of the situation that we're in. Some patients talked about accepting that this was a safe alternative given the scenario. Some people talked about the preference of telehealth visits over in-person visits, and specific preferences for video visits over telephone visits. When considering technology satisfaction and limitations, 10% of patients talked about this. They talked specifically about system failure, user unfamiliarity with the interface, internet connectivity issues, and things like that. When we talk about factors for successful integration, 6% of patients talked about this. 3 main themes came out of this one. So the first is patient empowerment through patient education about diagnosis, symptom management, medication management, and prognosis. The second theme that came was encouragement of social support through family and caregiver assisted history and physical examination. What I mean by this was that patients often said that the telehealth visit was easier when they had a family member with them to help with reporting of symptoms and things like that. And the third is improvement in telehealth accessibility through family and caregiver assistance with software and technical equipment. So some patients, especially older patients, talked about how it was very important to have family members with them to help with the setup of a video conference or a telephone call. The last one were recommendations that patients gave for optimal scenarios in which telehealth could be used. The most commonly cited one for that was that patients thought that telehealth would be best for follow-up appointments for established patients as opposed to for new patients. The second one was patients thought that telehealth would be much better for stable diagnoses and visits depending upon the patient's needs, like as long as they didn't require any in-person services such as lab draws or injections or anything like that. Next, they talked about non-emergent chief complaints, anything that didn't involve an immediate threat to life or limb, they thought was best for telehealth. Medication management visits. A lot of neurology patients that we talked to said that they just had stable diagnoses that just needed a refill of medications or just a check-in on the dosages, things like that. And the last thing that patients talked about was challenges or ease with child and adolescent visits. So some patients talked about how telehealth was better for child and adolescent patients because they were in a space that was familiar to them. They didn't have to go to the doctor's office where they often feel anxious. And then some parents also talked about how it was difficult to have a toddler or like a 3 or 4-year-old kind of keep their attention span for the duration of the telehealth visit. So in conclusion, we kind of saw three major themes kind of come out of this study: positive effects, negative effects, and technology-related effects. So positive effects definitely were based on the fact that there was no commute time and the relationship that they had with the physician. Negative experiences, like by far, were based on the lack of a complete or a thorough neurologic exam from the perspective of the patient. And lastly, technological barriers and inaccessibility to the equipment needed for a telehealth visit. Of course, overall, patients thought that telehealth should be used as an augment and not as a replacement for in-person visits. So these are some of the findings that we saw through this study. That's all I have for now, and I'd welcome any questions that you'll have for me.
Catherine, you have your hand raised. You all can go on it. We're not that large of a group. You can just.
Oh, I was just clapping my hands. That's.
I thought
it was great.
I thought it was a raised hand. That was a clap. Okay.
No, it looks wonderful.
It was very good. Thank you.
Yeah, thank you.
Any questions, anyone? And as a reminder for all our poster presentations today, if we have a few extra minutes at the end and you think of a question between now and the end of the 3 presentations, do stick around. We are on a strict schedule. We only have this room for 45 minutes and we'll be kicked out. So, but if we do have time, we'll take a couple of extra questions at the end if we have time.
I am curious. I was just curious, how long were your interviews? Because that's a lot of interviews.
Yeah, so we had a large team kind of helping with the study. So this study was actually conducted during March to May of 2020. So that's when I was actually in 3rd year, and we had gotten kicked out of our clinical rotations because that was the start of the pandemic. So it was an 8-week period of time where we really weren't doing much. So a lot of students kind of pitched into these interviews, and the quantitative part of the interview didn't take that long. The first 3 questions, because they were just saying like any one of those 4 answers. The qualitative part, some people shared a lot more information, and some people were very succinct. So interviews could be anywhere between, I would say, 4 to 10 minutes at the max. 10 would be pushing it. But it was such a valuable experience to talk to these patients and kind of hear their experiences as it was happening, live, just in real time.
What was the question you asked them? Just using an interview guide or?
Yes, so these questions, if you look to the left of the poster, so these were the questions that we asked. At your recent visit, what type of telehealth visit did you have? So we wanted to confirm what type of visit that they had at first. The second was, were their needs met? And then the third was, would they consider telehealth in the future? And then the last question was an open-ended question asking for general feedback. And that's where we got the qualitative responses for the study.
Thank you. That's very helpful.
Yeah.
Did you do any analysis on the difference between the video visit or audio visit only, or video plus audio?
In terms of the qualitative experiences that we're seeing, or?
Yeah.
Yeah, so we actually just published the study in Neurology Clinical Practice. And so we also did an analysis of that as well. And so by video versus telephone. And for the most part, the same trends hold. The only thing that I would say is that for the physical exam bit, I think there was a difference in expectation for video visits versus telephone. So it's actually surprising because patients who had a telephone visit didn't actually cite that they felt that they didn't have a complete neurological exam, because I think going into the telephone visit, they expected that they wouldn't have a neurological exam. Compared to video visits, I think patients had a higher kind of expectation for what they wanted during that visit. So they cited, having being a little bit disappointed as the physician wouldn't have tested my reflexes as they would have in person, or things like that. So that was an interesting thing that we saw when we stratified by visit type.
Thank you.
Mm-hmm.
All right, we need to move on, Sharon. So if anyone has any questions of Sharon, if we have time at the end, feel free to ask. If not, you can contact Sharon through the attendees list on the web page. So we'll go to our next presentation. That will be with Julia Cohen and Jillian Massini on advancing health equity and telehealth.
Yeah, thank you so much. I'm going to jump right in because time is short. So we are joining today from the High Tech Center, which is a HRSA-funded national training and technical assistance provider supporting federally qualified health centers across the country in using health IT and telehealth. Health centers are HRSA, BPHC, or Bureau of Primary Health Care funded, community-based, and patient and community-driven organizations that provide comprehensive, culturally competent primary care services. That's really the health center program mission. And health centers deliver care to the most vulnerable individuals and families, including people with low income, people experiencing homelessness, migrant agricultural workers, veterans, and so on. And in total, serve 1 out of every 11 people in the country and 1 out of every 3 people living in poverty as of 2019. Most importantly for our brief presentation here today is that as of 2019, nearly 1/4 of health center patients are best served in a language other than English, with much higher rates in many parts of the country, and many of whom are low income. So as many of you likely know, prior to the pandemic, federally qualified health centers were only permitted to provide telehealth as originating sites, meaning that the patient had to be in the health center in order to get telehealth services that were reimbursable for the health center. As such, before COVID-19 hit, the health center patient who was accessing telehealth services was in the health center and therefore could be accompanied by a health center staff who could assist with interpretation, or somebody who could assist with sort of navigating the process, and that was generally live. And so whether that was a health center interpreter or someone who could connect with Language Line or something like that, another third-party service in the visit. In 2020, health centers were suddenly able to provide distance site telehealth, meaning the patient was elsewhere and not based in the health center, and were doing so at very high rates. In 2019, less than 2% of health center visits were done via telehealth, but by late April 2020, or early May, nearly 60% of health center visits were telehealth visits. So accelerated adoption in the context of the pandemic challenged resource allocation and workflow planning that would typically be used to successfully launch such a large change. Suddenly, health center providers were doing telehealth to and from home with little guidance or training tailored to health center priority populations. And as it relates to patients with limited English proficiency, providers found themselves using personal cell phones for 3-way calls to conference in an interpreter, attempting to provide telehealth instructions by relying on Google Translate, or using other approaches that required a great deal of additional time and energy and didn't necessarily result in a patient-centered experience. This highlighted the importance of consistent and effective workflows for caring with patients with limited English proficiency that are responsive to the specific needs of the health center setting. And there was a need for immediate term strategies that could be implemented to better serve LEP patients or limited English proficiency patients, as well as longer term strategies that improve organizational readiness and capacity to provide patient-centered virtual care to those patients with limited English proficiency. And with that, I will hand it over to Julia to tell us more about these strategies.
Great, thank you, Jillian. So I'll be speaking about some of the strategies that health centers can and have been utilizing in order to provide telehealth services to their limited English proficient patients. I'm going to dive into the short-term strategies that can increase access to care for health center patients, even with larger systemic barriers at play. So the first type of strategy that I'll discuss are interpretation services. Interpretation services are effective in improving quality of care regardless of the method in which the visit is conducted. But it's especially important to be mindful of language accessibility during telehealth, where there are more opportunities for information to get lost in translation. For example, it might be less evident to a provider that their patient isn't comprehending their recommendations when they're delivered virtually. Therefore, it's really important that limited English proficient patients have the resources to utilize interpretation strategies when participating in telehealth visits with providers who don't speak their language. So third-party services are one strategy that health centers can use to provide real-time interpretation. These tools can be used for audio-only or video visits using multi-party functionality within a telehealth platform. Third-party interpreters can be generally located anywhere, which increases a health center's access to interpreters when needed. It's important to remember that third-party services are considered a business associate under HIPAA, and therefore they're required to protect patient data. Health centers can use technology functionality that support quick and effective interpretation. And one example of this is Zoom language interpretation. So Zoom doesn't provide their own interpreters, but the software allows participants to designate a person as an interpreter, such as an interpreter from the health center, and then project audio in the participant's dominant language instead of the speaker's language. So the patient would hear the conversation in Spanish instead, while the provider is speaking in English. This serves the purpose of reducing the length of a bilingual visit, since the conversation doesn't have to be repeated. Another example is three-way calling functionality in Doxy.me or Doximity, where the link can be sent to both the patient and the interpreter by the telehealth coordinator or member of the care team, which eliminates the need for the provider to conference in the interpreter at the beginning of the visit. Health centers can also utilize resources that assist limited English proficient patients with the use of telehealth. Resources in other languages raise awareness about the efficacy and ease of telehealth and can help with technical support. Using these strategies together, particularly when facilitated by a telehealth coordinator or other care team member, who can ensure that providers and patients have what they need to be successful with remote interpretation in advance of the appointment, has anecdotally been shown to be a successful approach in health centers. And you can scan the QR code on the top left to access all of HITECH's resources, including an annotated list of EHRs and patient portals that are available in languages other than English. One thing that's important to remember too is that telehealth is more than just video and audio calls. For example, text message check-ins with patients can be used to remind patients of upcoming appointments and follow up on their health status or care plans. Intake forms and asynchronous visits can be set up in languages other than English, so that the appropriate pre-visit questionnaire is populated with the correct language and sent to the patient. And there are also many COVID-19 specific fact sheets with information in up to 35 languages, and those can be linked in automated confirmations that are sent to the patient. So ultimately, video conferencing should be a long-term goal because it is demonstrably better for providing care. But audio-only visits have been mostly reimbursed for the past year and do provide a beneficial interim step for care management, but again, are not the ideal long-term solution for telehealth. And now finally, I'll just spend the last few minutes talking about long-term strategies that can ensure access to telehealth beyond the solutions I just mentioned. So one thing that health centers can do in the long term is share interpretation capacity with other organizations. Third-party interpretation is widely used because it's easy to use and there's a breadth of language options. However, the high cost can sometimes be a significant challenge. So health centers can implement pooled video interpretation across a network of organizations using voice over IP or VoIP technology instead of traditional phones. This allows a number of member organizations to achieve economies of scale by sharing interoperation through a high-quality video network. Also in the long term, it will be advantageous to advocate for greater language variability among the provider population. Limited English proficient patients will greatly benefit once the number of multilingual providers matches the demographic makeup of language variability in the US. But the availability of bilingual providers hinges on the removal of various structural barriers. The first of which is educational access. So offering multilingual care requires that people who speak different languages have opportunities to be trained medical practitioners. And there are various systemic inequities entrenched in the US education system that disadvantage students who do not speak English at home. So advocating for educational equity among limited English proficient patients is an important first step for students to realize their full educational opportunities. The next important barrier to address is graduate medical education. It's useful to include foreign language instruction in medical schools so that students who are already bilingual can learn specific medical terminology. This step is necessary for bilingual providers to be able to comprehensively offer care in a language other than English. Another important step is health systems trainings. Bilingual training programs within health systems can help increase the linguistic capacity of providers within organizations. And then finally, the last barrier is just retention. So even when multilingual staff are hired and trained in an organization, it's important to think about retention efforts. Leadership should recognize the burden of multilingual care and support and compensate their staff accordingly. So these long-term strategies will be useful in achieving the ultimate goal of multilingual care, to effectively match providers and patients who speak the same language to provide care in person and through telehealth. That's all we have today. Thank you so much. Open to answering any questions that anyone might have.
I'd like to ask a question about your long-term strategies. Is there any thought or effort in educating patients about the complexity of our healthcare system? I know that we've focused a lot on training providers, but I work in an FQHC where I see people from so many different cultures, and I just feel like it's overwhelming. Even though I'm bilingual and bicultural, I can handle two, patients from two different cultures. And yet there's so many other cultures that walk through my door, and it's just overwhelming. But at the same time, I don't see that we're educating our patients at all about the complexity of our healthcare system. And so I think that's where there's a space that we need to educate our patient. Have you considered that as a long-term strategy, or how to go about that?
Yeah, I think we've done lots of, what do I want to say? There's a big space between the all of the possible options, right? And one of the things we've talked a lot about is bridging that divide. And there's so many different approaches to doing that. Some is providing instruction and information in people's language, culturally appropriate, so that they're better prepared. So it's less on the provider. And that requires setting things up appropriately and things like that, which can still be a heavy lift on the health center itself, but less on the provider. And so that's where the sweet spot seems to be now, though still it is a lot of work for everyone. And that's certainly part of it. But how do you teach a whole community about the complexity of the healthcare system when people have very complicated lives, right? I think that's a very big question. And I think Julia was going to weigh in as well.
Yeah, I was just going to say, that's a great question. I think one thing we briefly mentioned was these fact sheets that have been written about COVID in up to 35 languages. And I think that's just one example of how a very specific piece of information can be widely disseminated and shared among people with who speak multiple different languages. But it's hard, I guess, to think about what sort of fact sheet might look like explaining the complexities of the health system. And I think breaking it down into smaller chunks might be a good place to start, but that is ultimately definitely a great long-term goal.
We have a question in chat, and I'm sorry we don't have time to have everyone answer it. From Lindsay Ray, thank you to all the presenters. One question for all the presenters: is there one go-to resource that provided you insight as telehealth was widely implemented in your work organizations? And Lindsay, if you would, you can reach out to all our presenters through the attendees list. And if you want to follow up with them, or if the presenters want to take Lindsay's name down, and she is also in the attendees list, and maybe touch base with her. I want to thank all our presenters today for presenting. I'm sorry we're running out of time, but we will need to get to the next set up for the next session after this. Everyone, it was excellent. Please don't forget to go to the People's Choice poster and link and vote for your all's favorite poster. And thank you all, everyone, for joining us today. We are going to be actually kicked off this, and I noticed Ash, you're here. I don't know if any of the other presenters for the next session are here, but we do have to go out and come back in. So we will, if you all follow us, we'll see you in just a few minutes. Thank you.